with family physicians, it's important that we explain exactly what it is that they need to do, the condition and its treatments. It's important that you let patients know that this is a condition that can be controlled, but we cannot cure it. It's also important to let the patients know that they should not be afraid of certain medications, which I will talk about shortly. The use of topical treatments with the details of the application and how much to use. You shouldn't skimp on certain things. And if possible, demonstrate how and when to use these things and back up this with written information. Now, I used to give patients information leaflet that I had typed up very prettily and have some nice, emojis and put there with the patient. The patients they don't read them. So what I found out was good was after educating the patients, I make them tell me back and then write out their own key points. Now, once they've done this, then they've heard and assimilated, and they've been able to give you back writing. They would hold it. And I say, write your name on it, and that's your own care. So once you take it, you've passed. Take that as your own post information leaflet, as the case may be. Very practical advice. Daily skincare routines. This is important because when you start to talk about moisturizing and bathing and clothing, it looks like you're talking nonsense, but it's very, very key. Moisturizing is a baseline of atopic dermatitis management. What moisturizer to use is less important than moisturizing, applying the moisturizer. So what emollients to use, so long as it's not a steroid or it's not a triple action, is not as important as ensuring that they do moisturize the skin. Bathing, how do you have your bath? The average person who is having a bath in Nigeria is using a sponge and probably a medicated soap or even a regular toilet soap. Soap in itself is drying. Medicated soaps are even more drying, and then they strip off the protective commensals on the skin. And so we say, as much as it is up to you, use a synthetic detergent called a Syndet or simple toilet soap and try not to be too dry in your bath. Sponging, preferably not. How often should you bath? At the very least, you will bath with your sponge and soap, because I know that it's difficult to tell Nigerians not to use a sponge and a soap at least once a day. And then you rinse off the other time of the day. What's the temperature of the water to use? Preferably cool, not hot water. Warm to tepid to cool is preferred than hot water. In fact, hot water should be avoided, even for babies. Yes, we shouldn't even use hot water because they lose more body water the more they bathe, and then they lose even more body water when they use hot water. Clothing choices: cotton, 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 natural fabrics, breathable fabrics, lightweight, light color, preferably not tight on the skin. So people say jeans, for instance, denim is cotton. Yes, but it's harsh cotton, is hard. So it will cause a little bit of irritation. This clothing is also your beddings, is also the pillows that they sleep on. So these are all very important and they should be talked about. Doctor, I beg, I've used all these creams, Jerry, nothing is working. That's the importance of saying the moisturizer, the emollient that is used, is less important than for them to use it at all. I think I want everybody to remember that. It's important to use good creams. It's important to use not steroid-based creams. It's important to just use a cream, but make sure you use it. Flare-ups, we'll talk about that in a minute. So I want to put up this. This was, sorry. Baseline therapy. So if you look at the stepwise care in managing AD for those who are primary care physicians here, the baseline is to moisturize, apply the emollients, and use the emollients and use it well. It's important for us to talk about this baseline care because if you look at it across the step, the baseline therapy, the basic therapy is always there. So it's the most important thing to do, which is why your counseling must emphasize that as well. When you move to mild AD, where you start to have not just the dryness, but evidence of itching, recurrent itching, and slight lichenification, then you now bring in corticosteroids because there is inflammation. We've talked about it that the pathos of AD is the defective barrier and the inflammation because of the loss and the skin barrier that is not able to defend you anymore. So reactive therapy with topical corticosteroids. Topical corticosteroids are a range from mild to moderate potent and severe, mild to moderate and potent and very potent. This, this we cannot, I don't talk much more about steroids here. It's a big deal. But it's important to realize and to note that when you do use topical steroid, when the patient is active in a flare, it's best to go high, treat to completion, and then drop. And don't play with it. A lot of people know that dermatologists use steroids, but because they know that steroids also are dangerous and we warn against steroids, they play and they tease the body with using mild steroids for a long time, so much so that patients think that it's best to add the steroids to their body cream and use like a regular emollient. It is incorrect. Reactive therapy, you apply the topical corticosteroids as has been prescribed, moderate to mid to moderate potent, and then you drop down. Then you also can consider the PD4 inhibitors like crisaborole, which is it's not available in our country. So this is obviously not from Nigeria. When it's moderate AD, there are criteria to say mild, moderate, severe AD, where you talk in terms of the scores of AD. Again, that's a big deal. AD is wide, and I'm sure we cannot cover it. So I'm just trying to bring it really concise so that we can have a Q&A, and anything that is not clear, we can correct. So when it's moderate AD, when you have more than body affectation, there's a criteria. So depending on what criteria to use, if you're using the SCORAD or the EASY score, then you can say add proactive therapy. Sometimes you might now need to use oral corticosteroids, even in your moderate atopic dermatitis. And of course, when it's severe, when we go to oral systemic therapy, including phototherapy, including biologics. So we have them depending on what is available. Methotrexate is something that we use in our environment quite well. People are afraid of it because it is one of the medications that is used in oncology, but it has been shown as an immune suppressant and a disease-modifying drug. It's very effective in atopic dermatitis, as well as cyclosporine and azathioprine can be used. Dupilumab is one of the newer biologics that have been used in atopic dermatitis. This is not available in our environment, but it's being used. JAK inhibitors are also being used, and these are therapies that go forward. By the time you're having to have a patient use that, obviously they've come to us. And I had said that this community webinar is tailored to primary healthcare workers. So by the time it's getting to moderate, I'm assuming that they will come to the dermatologist. So can I just reiterate and ask that tell you why moisturizing is key? It's going back to the skin barrier dysfunction, where because we have epidermal barrier dysfunction, there is increased transepidermal loss from the skin, and the skin is dry. That's open. That dysfunction also allows allergens and microbes in. When you use harsh soaps such as medicated soaps and hot water, it further disrupts the barrier. So when we use moisturizer, it helps to create an external barrier, like sort of seal it, especially when we use occlusive moisturizers, so that we don't lose more transepidermal water. What are the types of moisturizers? From lotions which have less, excuse me, a little bit more water than oils, to humectants which have almost no water at all and attract water from anywhere. All these are emollients. We will say moisturizing is the act of using emollients. So actually we should be using the word emollients, right? But so lotions, they spread very easily. Their effects don't last very long. Creams are better because they're equal parts 50% water and oil, and they spread easier than emollients, and then they absorb into the broken skin quite quickly. But of course, you have to reapply and reapply creams, and it's good because they are cool because of the water content. They are cool and they help and soothe the body as well. Ointments and oils are occlusive, and because they contain more oil than water, if there's water on the skin when the patients have had the bath, it traps the water and helps do a lot more moisturizing. So it's very, very important to explain to the patients why they need to do not towel dry or not keep their skin very dry before they moisturize. So some people towel dry a lot. In atopic dermatitis, it's important to moisturize on damp skin, not wet skin, but damp skin. Humectants like urea and glycerin help attract water from the atmosphere, from the dermis into the layers of the skin. And so they help to keep it all sort of to keep that when you combine them with occlusive moisturizers like the petrolatum, it really helps to collect water from everywhere and help the body keep it moisturized. Practically, this is what I was talking about with how much should be used. If you think about it, that an adult with atopic dermatitis requires about 140, let's say 120 grams of emollient per week, and a child needs maybe just slightly less, it tells you how much of what they have to use it a lot. So they have to keep moisturizing. And so this was a slide I presented at the Glowdem, and it was an eye opener because if you think in terms of, again, I didn't want to call any products, but if you think in terms of the 450 ml tub of this product, this ointment, it will last them just about a week if they're using it properly. So it's expensive to manage AD properly. Quick word on antibacterial therapy. If you remember the picture of the little girl that had huge lymph nodes, in AD, you have colonization, Staphylococcus aureus colonization, like I had mentioned, and this contributes to or worsens the flares in AD. Practically, it's best to teach the patients how to do bleach baths or wet wraps. And again, swimming can help. And we have some of all of these flyers that can tell you what to do. But I just wanted to share. I'm hoping. Sorry, Dr. Tane, did you hear the when I had that video? Was there any? Did you hear the? Did you hear the conversation, Dr. Otane?
Yes, yes, it
So
was quite
we
clear.
heard.
Yeah,
Okay,
yes.
so because I'm about to play a video, this is important. I'm about to play a video, so please listen to this video. So can you just talk to me about how you moisturize your skin? How you put cream on your skin? Tell me everything. After your bathing, all those things that you were telling me just now. I used to clean my body. When? In the morning or evening or afternoon or night. Okay, even when you're in school? Yes. What is it? What do you use to cream your body? My cream. Do you know the name of your cream? Yes. What's the name? Vaseline and E45. Fantastic. You put it together. What about sponging your skin? You use sponge? I know a sponge. Very good. You're not supposed to use sponge. Just your soap, right? Yes. What about your towel? Do you towel your skin very, very dry? No. What do you do? Not dry. I used to use my towel. So you want some water to be on your skin? Yes. Why? So that sorry. That you can now put the cream. Fantastic. What about bleach bath? Do you know about a bleach bath? The jig bath? Yes. Do you know how to do it? Tell me. I'll put the water inside a bath. I'll not put the jig. How much jig do you put? Small? Yes. Is it your mommy that measures it for you? Okay. And then? I'll go inside. When I finish doing the jig bath, I stay on the rack. Then I'll put the clean water on my body. So you rinse with clean water again. And then you now. How long do you stay in the jig bath? 10 minutes. 10 minutes? Who counts the 10 minutes for you? Who counts the 10 minutes for you? How do you know when it's 10 minutes? It's my mommy that used to ask my daddy if it's 10 minutes. Okay. But what was it you were telling me that after you count 1 to 100, then something will happen? That when you are inside the jig bath, what happens when you count 1? You said you count 1 to 100. Are you counting 1 to 100 now? Sure. What happened when you count 1 to 100? You said you told me something before. When I count 100, I'll stand up. Very good. I'll count 100 again. I'll come out and I'll stay inside back. When the inner is 10 minutes, put it aside. But you rinse first with clean water that doesn't have jig in it. And you now stay on a rag so that your body will now small. But you wait for your body to be very dry before you put your cream. So how many times do you do the jig bath? Once how many, like every month or every week or? Oh, so can you just talk to me about? Okay, so thank you. I hope you got that. So the importance of sharing that video, I don't know if you all noticed actually, is I have permission, by the way. I had permission to use that video from the parents. We have a written informed consent for that. And the importance was That was a little boy who now knows how to do things himself. So he tells his mom, I think it's time for me to do this bleach bath. I'm scratching a
So,
bit more. Sorry? Okay. So that was important. And I try to show that because if you teach the patient, if you teach the child, then the child would even help the mother. And that also means that they're owning their problem. And so they're taking an active role in managing this chronic skin disease. And this is important even for their emotional and mental well-being, because supporting them emotionally is important. So if you understand the impact or the psychological impact of living with this chronic disease, then you can understand why we as the caregivers need to come together with them and listen to them and hear where their problems is and then take it up little by little. We have to teach them techniques of coping with stress like yoga and maybe just going to a cool environment or going swimming if they can. It's probably a good reason to teach big children how to swim. Sleep disturbances cause a lot of people. I've had a family who were beginning to have relationship problems because the child was not allowing anybody to sleep. And meanwhile, they had pets in the house, and that was the problem, but they weren't communicating. I want to go towards the end of my presentation by talking about how we should improve communication between patients and the healthcare teams. And the healthcare teams is all of us here, pharmacists, nurses, GPs, all of us pediatricians. If we are all engaged in what it is that we really have to do, chances that we'll be sharing the same information. There's a lot of misinformation. So what are the questions that we should be asking? I think we have said a lot of them there. And what information are we sharing? We have said a lot of them there. It's important for us to have active dialogue, just like what we're doing now with other healthcare workers, and let them tell what the patients are telling them. And so we can be involved in this decision making. One of the things I do is I collaborate with Farm Alliance, they do the master classes, and this is online. You can check out this video whereby they taught patients that came into their pharmacy not to use triple action for quick problems in trying to solve a patient with AD skin. I'm just going to move on. There is a lot of impact on daily life. Quality of life is really reduced because they can't sleep well, they can't manage the stress. So when I tell patients that and tell the caregivers that you cannot sleep with a fan, it's preferably to sleep with an air conditioning. They're asking me, are you going to provide the money? So of course, if we can't afford air conditioning, we need to keep the room cool. But if you have a fan, chances are these patients also have other atopic conditions. So the fan might exacerbate it. That's one. But it's also important to have, as much as we say we want the rooms to be cool, some people take it to the extreme and always have the air conditioning on practically all day, those who can afford to. In which case, all the allergies that they may have, remember I talked about the mites, are just circulating in the air because they're not having cross ventilation to keep any pollens or allergens moving out of the room. So little things like that are actually quite important. And these are the things that cause some challenges in treatment and management. Sometimes we actually have to go into people's homes to see where the problem is. I've done home visits for a few patients, and it really is helpful. So I'm going to end by talking about resources and community support. That it's important for us to have patient advocacy groups, access to educational materials, and online forums for ongoing support. There's a very important patient group is globalskin.com. You can check it. We started an atopic dermatitis support group in Nigeria. That's the link for those who want to join in. It is not for consultation. It is for support and patients supporting patients, caregivers supporting caregivers. I think some of the players, Dr. Nimi, she's a doctor, but she also is atopic and has a family of atopy. So she was one of the pioneers in this with Dr. Atinuke Waje. If she's in the forum. So kudos to them. And hopefully we're making progress in this. Um, One of the things I have reiterated is moisturizing as part of treatment. Now, we've seen that moisturizers can be quite expensive. And you and I can bear witness to the fact that HMOs, first of all, don't find that they want to even pay for dermatology consultation. Least of all, pay for medication that they're calling creams because they think it's cosmetic, or if it is biologics, it's too costly. So luckily, because I mean we've pushed for this, if we all say this over and over and over again, it's possible that insurance companies, I think they now would have to pay for uh, creams, emollients as part of medication for atopic dermatitis, as long as we can prove it. And this is why it's important to let people know that AD is not just dry skin. That's a myth. It's not a fact. AD is not contagious and that only children get AD. I think in this address, we have seen that that is not correct. But more importantly, we know that the WHO, just in the recent assembly, actually put global skin disease as a global public health priority. So maybe now HMOs will be able to answer us more that derm skin diseases is not cosmetic. It's important for us to push that narrative on. We are making the global movement. Nigeria is doing a lot with the International Society of Dermatology, International Society of Atopic Dermatology, where some of our colleagues have even put up videos. They're online. You can Google it and check it. We're collaborating with a lot of international partners for a lot of skin initiatives with Sub-Saharan Africa and the WHO. And I think, Dr. Tane, this post quiz, what did we find out when I asked her, what is the best emollient to be used in AD management?
Okay, a lot of people put in Vaseline, petrolatum, ceramide, paraffin. Okay, someone says the one you can afford and tolerate all the time. Uh,
Fantastic. So I would say that was our answer. If these people that are doing this webinar were giving prizes, so that person would have gotten the prize. The one that the patient uses is the best emollient to be used in atopic dermatitis management. I think if we take nothing home, we should remember that if it is the itch that rushes, how do we not allow the patient to scratch? It's not about giving all the antihistamines in the world. No, it is to moisturize. So to recap and to conclude, AD is chronic. AD has familial tendencies. AD is, we can manage AD. If the first responders know that managing AD is about educating the patient, explaining to them that this is not contagious and it is not a problem from your village, and that if you do the right things, you would not have complications of AD, which can include skin sepsis, and seek professional dermatology advice as necessary. I think we will say we've done some very good stuff. By all means, join the AD support group if you know. We are trying to do an atopic dermatitis registry in Nigeria. There's that project on the way. Many of the people in this platform are part of it. And like I had mentioned, that the African atopic dermatitis management guidelines is also in the works. I thank you for listening. I hope I have created a positive ripple effect in managing atopic dermatitis. And I'm inviting everybody who is on this call to attend the 19th Scientific Conference and AGM of the Nigerian Association of Dermatologists. Thank you. Riri
Thank you
out.
very much. Thank you so much, Dr. Ere, for the very thorough, comprehensive, and really interesting presentation. So I'm going to do a quick summary before the questions come in. You can drop your questions in the chat box um, while I just do a quick summary of what we've heard this evening. So we've listened to a presentation on AD, atopic dermatitis, which was introduced as a chronic inflammatory condition characterized by episodes of intense itching and severely dry skin, resulting in a decline in the quality of life for both the affected individuals and their caregivers. We also learned that this condition is most prevalent among children, though seen in adult population as well, and that the potential triggers for AD include genetic predisposition, environmental factors, and skin barrier dysfunction. The speaker elaborated on the pathogenesis of AD, detailing the roles of genetic factors, compromised skin barrier, and various triggers such as environmental allergens, pollen, dust mites, and also stress, various forms of stress, and then weather. She also talked about the role of microbiota on the skin. And some findings were reported, including sensitization to mites and cockroaches, and even allergens from insects, to which some patients with AD in a study in Lagos reported sensitivity. On the diagnosis, the speaker reviewed the UK Working Party criteria, which stipulated that a diagnosis requires the presence of itchy skin along with other factors, onset before 2 years, and other symptoms. Also, the American Academy of Dermatology criteria was discussed, which categorized several features into essential, important, and associated classifications. The presentation included typical signs and symptoms of AD, along with photographic illustrations depicting various manifestations across different age groups. He also talked about the mimics of AD, including scabies, contact dermatitis, psoriasis, and seborrheic dermatitis, but that the chronic remission and relapses of AD, as well as other typical presentation of AD, quite set it apart. Practical management strategies were addressed, emphasizing the significance of moisturization to enhance epidermal barrier function and emphasize the key role of moisturization to the treatment of AD. Also, the role of counseling and educating the patient was underscored. The speaker cited a study that recommended that adults with AD should use 70 to 140 grams of emollient weekly, while the recommendation for a child is between 50 to 100 grams per week. Also, antibacterial therapies and supplementary treatments such as bleach baths, light fabrics were also mentioned as part of the management plan. She also mentioned the role of steroids, but should be used as reactive therapy and not for the long term. The importance of emotional and mental well-being of patients was highlighted, along with the need for enhanced communication between patients and healthcare givers, as this condition significantly affects the daily lives of those affected. Common myths and misconceptions about AD were addressed, clarifying prevailing misunderstanding. In conclusion, the speaker urged patients to seek professional assistance and introduce support resources, including the AD support group and the ongoing AD guidelines and several ongoing projects with stakeholders. Thank you. If you have questions, please, you can put your questions in the chat box. What the heck?
Can you hear me? I want to put up
Yes,
something about
I can hear you
the.
now.
Can you see this bleach bath for sub-Saharan Africa? Can you
Yes.
see the slide? Okay, because I saw one of the questions. Sorry, I just wanted to quickly push this out because it's important. Dr. Onila, I think, was the one who asked about bleach baths for training. So this is something we did, and it should be on the International Society of Atopic Dermatitis website. If it's not there, I don't know. We did it for WHO, Dr. Chim Somogu and myself, with some of our youth nurses. So simple things are so the question, get the materials needed. You see, we have the petrolatum there. We have 4 liter kind of buckets. We have sheets, white sheets, cotton sheets, and one cup, one cup full of household bleach to 4 liters of water. So this container, Dr. Onila, 4 liters of water. So that's step one. You create it, soak the, if they don't have a bathtub, that is, which is what we found that many people don't have, soak the affected body parts in the bleach baths. That's what the little boy was describing, what he does. Okay. And then you rinse thoroughly with clean water after 10 minutes soak. Okay. The parts dry, and then apply emollient to damp skin. Now, if there is active inflammation that you want to do a steroid bleach bath, you would actually now put usually with 1% hydrocortisone because you're going to cover, so you don't want anything too bad. So you apply that to the cotton clothing that you want to wrap them with, and then wear cotton clothing on top of it, and you repeat as necessary. So that's a bleach bath wet wrap, which we sort of put together because we gathered that some areas don't have water, running water, and some areas, some people don't have bathtubs in their homes. So that's almost like a combination. But I think the key thing there is one cupful of household bleach to 4 liters of water. Dr. Nila. So Dr. Tane, sorry, please continue.
Thank you. Thank you. Please, hello? Can you hear me, please?
Yes, ma'am, we can hear you.
Okay, yes. Thank you very much for your presentation and for the clarity of it. I just want to know, for how often do we have to do this bleach bath? I know that someone asked, but it was not in the answer you gave. Like, how often should they do the bleach bath?
Thank you,
Is it
ma'am.
something to be done weekly or twice weekly or something like that?
So bleach baths are for flares. It was in the presentation that when they are having
Okay.
flares or um, um, exacerbations, then you do bleach baths,
Okay.
wet wraps or bleach baths.
Okay.
They're not a regular thing. But what I
Oh,
do
all right.
so advocate is that because what we're trying to do is decolonize the skin of staff so that and then also when you do like a bit of a wet wrap, so like the last one that I showed you where we did like almost like a bleach bath cum wet wrap, after they've done that, it also prevents the children from scratching. So it was Dr. Chimsom. It was very interesting that they do it's like a salad of a bleach bath and a wet wrap because people don't have running water somewhere down where she practices. So that will also stop them from scratching. They are not able to get onto the skin when they after doing the bleach bath, do not do a bit of wet wrap. But the bleach bath or wet wraps are for flares and exacerbations. They're not a regular thing. Thank you.
Okay, someone is asking, how can one differentiate AD and lichen planus in an adult? Does AD flare up, or is itching worse with sweating?
We
Hello?
assume that yes, I just realized I was muted. We assume that when we are hot, that's when we sweat. And so heat is not a conducive environment for patients with atopic dermatitis. So yes, ordinarily one will say AD will flare up when you're sweating, but not sweat like a regular, but when you're in a hot environment, yes, AD can flare. Atopic dermatitis and lichen planus are not similar. Lichen planus is not even a typical mimic of AD. However, because lichen planus is very itchy, one can think about it that yes, because we say the each AD is itchy, LP is itchy. But the history and to the experienced eyes, those who speak skinnies, you would know the difference between AD and LP. But the history is particular about helping. Lichen planus is not, though it's autoimmune, it doesn't have that familial history like AD does. And they may not have the stigmata, the clinical features that we see in atopic dermatitis, as I showed. I hope that helps.
Thank you
Hello,
very
sorry,
much.
we have some questions. Moderator, we have some questions on the live stream. We had to open a live stream because we had reached full capacity. So we have about 20 people watching. And Dr. Henshaw is asking whether you can say something about follicular AD, especially in adults.
Okay. Sorry. Can you hear me?
Yeah, we can.
Yes. So again, this as we when you have a very seasoned dermatologist in it to bring up those stories. So the whole point about it. So when we talk about um so there's a difference. So stigmata, we talk about phenotypes of atopic dermatitis. Just like I had mentioned that even in children, they tend to have that follicular papules. In adults, you can have a follicular accentuation, i.e., the skin is like standing on end, almost like it is. How do you put it? Like it's what's the word? What's that word? Gritty, like grater. So it's a phenotype, it's a presentation, but it's not folliculitis. It's just that it is standing on end. So you can actually uh, describe that phenotype of atopic dermatitis. It's seen in adults. They tend to have it usually on their trunk and most times on their elbows. So yeah, thank you. Goosebumps. Thank you. Like goosebumps. So yes, that can be a phenotype of AD, but you also have to rule out that they don't have any other problem. And it should be generalized. It's not like it is post-inflammatory hyperpigmentation. So it's different from folliculitis, which can happen when you do have like a furuncle or something. No, it is the skin, is the phenotype, the way the skin looks. So you would say, yes, this patient has AD, coupled with the history as well. I'm saying about crisaborole, yes, it was mentioned. I'm saying, Dr. Tani, are you going on with the questions that are here? Because I'm saying
Yes,
some questions. Okay.
yes. Someone is asking, when should bleach bath be recommended in AD patients? Which should be applied first, steroid cream or emollients?
So the steroid cream is the medicine. Anytime you have a medication, you have to use the medication before the emollients. So the steroid cream should be applied, but we have to be careful that if the skin is really broken, there's a difference between escoriation and clear broken skin where there's almost like an ulcer. You don't want to use steroids then because it will worsen it. But whenever you want to use a medication that is topical, the medication goes on first before the emollients. I hope that answers the question.
Thank you, Ma. Um, Someone else is asking, thank you for the informative presentation. Many patients with AD also struggle with PIH, and that's post-inflammatory pigmentation, hyperpigmentation. What is a safe and effective way to treat this hyperpigmentation without triggering flare-ups, especially considering the potential risk as with various cosmetics?
Okay.
Okay.
Good, very good question. And if you were at the presentation, one of the slides showed an adult patient who, in the calm state, had multiple post-inflammatory hyperpigmented, almost like nummular, like discretes on the lower limbs. And that patient, when everything was calm, when the patient was not in an acute presentation, was most concerned about the discoloration. However, I mean, most times you want to be careful not to just start because, like you said, they can easily flare. If you moisturize properly on a regular basis, it fades. So your counseling and your education actually has to come in. If you allow patients to push you into wanting to correct discoloration, when they are not in remission for a long time, chances are you're going to be going into some sort of vicious cycle. Okay? Vicious cycle. You don't want that. If they regularly moisturize, effective emollient use will actually fade the discoloration to the barest minimum, whereby you might now want to help with a particular pigmentation cream to use it. But I can't give, and I don't know that it is right to give um, a skin lightening agent when you're trying to take care of PIH from AD, because first of all, it's widespread, it's not too localized. And secondly, just like you rightly said, the products or some of the active ingredients may trigger a problem. So you might want to do a patch test first and see that they're okay when they have been in remission for a while. And then you take it up from there. So you'll be thinking about PIH control for adult AD patients who are now in remission for a long time, not in pediatric age group, because they still have a while to go.
Yeah. Thank you, Ma. For want of time, we'll take one more question. Okay, someone says, thanks for the nice presentation. Newer creams like crisaborole are worth mentioning. So also, when do we say particular therapy has failed, and when do we need to move on to secondary therapy treatments with dupilumab and JAK inhibitors?
That's a very good question, which was also mentioned in the presentation. Crisaborole was mentioned in the presentation. I talked about it, that it was a PD4 inhibitor. And the systemic medication like methotrexate, cyclosporine, dupilumab, not available in our country, but I know a few patients who get it from abroad. So when you have, first of all, luckily for the most part in Nigeria, at least, not necessarily the rest of Africa, we have more mild to moderate AD. We do have a few patients, some patients that have severe AD. So you will decide that your patient has not done well when you move up the step ladder, like so. Now, if you think about it, that the skin cycle, because remember AD is chronic and recurs and relapses. So you take into consideration seasonal presentation, seasonal affectation. And like what I do, for instance, when I decide the patient using the SCORAD or the EASY score for those who are familiar with them, or any other sort of scoring tool, bearing in mind quality of life as well, because it's not just what you think clinically, it's how the patient also feels. One of my first systemic treatments is methotrexate, and it works. Many of the patients who have done well with methotrexate up to the point. So when I've decided that they are moderate to severe, for 3, 4, 5 months continuously with no change, with your simple basic therapy and add-on of corticosteroids periodically. Every now and then we give them a shot. In the Luth Skin Clinic, at least I can say what we do. We are not quick to give oral steroids for maintenance of atopic dermatitis, even when they are flare. And that's simply because our patients in this country can get oral steroids over the counter, and we are discouraging it. So you won't be able to control what this patient does without you. So yes, we do use steroids, but we know how we give our steroids, both topical or systemic. When you've decided that this patient is moderate, you're going to steroid sparing agents, you're going to methotrexate. That is usually one of our first line of systemic therapies. Dupilumab and JAK inhibitors are not available in our environment. Some of our patients have done very well with other JAK inhibitors, like the older JAK inhibitors, like what's the name? I forget. Starts with T. Uh, I forget the name because I don't want to say the trade name. So if somebody should please remind. Tofacitinib, thank you. So tofacitinib. So we have a few patients who have done fantastically well on tofacitinib, and what is extremely costly. And so that patient, particularly one patient I remember off the top of my head, is patient could afford it, but we're talking about medication that would be about 500,000 naira per month. How many patients can afford that? So we do have indications for use, but many patients can't afford it. So usually we keep them at increasing doses of methotrexate when they have been easy score severity of moderate to severe for a long time. Is atopic dermatitis linked with gut issues? Yes, I did mention it. It does. There is issues with food and all the microbiomes and gut microbes as well. However, the teaching is, especially where children are concerned, you do not um, starve the children of certain foods because you simply because you think that they may be allergic to it, or that's what is causing the atopic dermatitis. In fact, now they're pushing for you, especially with peanuts, that start them young with it and see how they do develop over time. They encourage taking peanut butter as part of the early diet for children. AD cannot be a 1 hour presentation. AD cannot be a 1 day presentation, especially for those who are very interested in it, because it is a wide and very important topic, I must say. And again, I will commend the Nigerian Association of Dermatology for this community webinar, because there is a lot to do, and hopefully we can do this even more and get our partners in atopic dermatitis or in skincare, generally skin health, to do better in caring for the patients. And of course, nation building will always be improved in this reign. Thank you.
A huge thank you to you, Dr. for sharing your experiences and knowledge. And thank you to everyone for engaging so thoughtfully. Thank you very much. I don't know if Dr. Nafisa or anyone wants
Hello, good
to.
evening. Yes, I think there's a little concern that there were a lot of, since it's a community webinar, that there were a lot of earlier questions that were not addressed. I can't see the questions because I'm actually live streaming, but that there were a lot of important questions that were not addressed earlier. So I don't know if we can just scroll through and see whether there's anything that, well, not repeating the questions, because some of the questions were actually repetitions. It's a community webinar, and I want to believe there are a lot of non-dermatologists in attendance. So if we can just add 5.
You mean here or in the YouTube?
No,
Oh,
there are a
chat.
lot of questions on the
Yeah,
chat here that were
even on
not
this chat
addressed.
box,
Yes,
yeah,
please.
there are many
I
So
important
think
one
we can
question
questions here.
here.
address them. Important questions here. Can you see them,
Okay.
Dr. Itane, or should we read them out?
Yes.
Maybe Dr.
Yeah. Oh,
Ko should
yeah.
read them. Please, let's not repeat any question, because some of them were just going around and around, especially if she has
Yes.
addressed
Yeah,
before.
that was what I was trying to. Well, the
No, there are a
questions.
lot of.
All right.
Somebody asked, can you replace Dettol and Savlon for bleach? That's an important question.
Okay.
Can you use Dettol or Savlon? Is bleach bath similar?
Thank you so much. That's a very
Yes,
important question. So, okay,
yes.
so while I'm responding to this, Dr. Otane, please, because like I said, we are here for a reason. So, Dr. Otane, can you just look through and see what else we haven't addressed? But in responding to this, so the answer is no. Savlon or Dettol is not bleach. Savlon or Dettol will be considered antiseptic, or what people like the way you talk about medicated stuff. So we're not replacing. A bleach bath is for staph decolonization. If we don't have any, I mean, bleach is household bleach. I think that's one of the reasons why it is used, because it's common enough and it's supposed to be very dilute. One of the problems we have with Savlon or even Dettol is Many people think that the more they use, the better. It can cause irritant contact dermatitis and worsen the outcome. However, if you are trying to take care of an area that is not clean, like maybe you find that, for want of better term, an area that is it's not clean, it's just untied, it's just dirty or something, you can use very dilute Savlon, like as if the way they would do in surgery, and do chlorhexidine and just clean the area, but not to soak in. No, remember that in the bleach baths, we talk about the percentage, 1 cupful of bleach to 4 liters of water. So we have that concentration of sodium hypochlorite, which is what bleach is, and it's doing what. So these studies have shown that it can actually do what it needs to do in terms of decolonization of Staphylococcus aureus on the body. So please, it will not be replaced.
Another question is how to distinguish heat rash from AD.
Okay. Okay, so thank you. Sorry. Sorry, I'm hearing noise. I'm not sure. Hello? Can you hear me, please? Because there's some other noise in the background. Hello, I was muted for a reason, I think. Can I go ahead?
Yes, please.
Okay, thank you. So, heat rash, medically we'll call it miliaria. Heat rash and atopic dermatitis, not the same thing, but very good question, because chances are it's children and they would have it a lot, not like adults don't have it. And but heat rash would usually affect covered skin if you're, and then the time it happens, and then the itching of heat rash will exactly be just when it is hot. AD, whether they are hot or not, if they actually have a flare, they will scratch. Heat rash with sweat, yes, just like AD, but AD is not peculiar to sweating. With heat rash, which is miliaria crystallina, the lesions are slightly different, but that might be a bit more technical. I don't know that I can, but most of them are flesh colored, the color of the skin. With atopic dermatitis, you would also see evidence of scratching and darkness and all of that. With heat rash, they look like fine, almost like pimples. They are fine. We call them miliaria crystallina. Again, with heat rash, you may not have the history of recurrent itchy skin or chronically itchy skin. The history matters. With heat rash, you look at it in terms of seasons and see whether you're having the same sort of problem. So the history of the patient, as opposed to just looking at the rash, will help if you're finding it difficult to differentiate it. This is now talking to primary health caregivers. Again, patients with AD can have malaria. So it doesn't mean that if you have AD, you can't have malaria. You can have both. You can have either, you can have both, but they're different.
There's another question on
Ma'am.
oatmeal creams. Oatmeal creams. What do you think about the creams with oatmeal?
So they are also good. So generally, again, like we said, the best moisturizer is the one the patient uses, especially if there are no steroids in it. And so there are many formulations for what helps the patient. So oatmeal is found to be quite soothing. Oatmeal, even oatmeal baths. They talk about oatmeal baths and oatmeal. So I don't want to call a brand name, but it's actually known to help with atopic dermatitis. They are quite soothing and they are very helpful because they also collect water. In one of the presentation slides, I had put things that are like humectants, and one of them, there was actually oatmeal involved. So yes, they're helpful.
Someone is asking, is AD linked with gut issues? Are there tests to guide on what one is dealing with?
I've spoken about that already. I responded to that.
I'll talk to the Mukhtar.
Okay, someone else wants to know if AD can happen for the first time in an adult.
I also spoke about that. I spoke about that. Dr. Nafisa, please, can you mute your mic? Sorry.
Sorry, you might stop me, but I think she has muted the mic.
Oh, okay. Apologies.
No
Okay.
problem.
One question just came in now.
Can I just respond to the last one, please? So, well, now I forget my train of thought. What was it again? If AD
If AD can occur in
For the
adults
first
for
time
the
in an
adults,
first time.
yes.
adult.
Yeah.
Yes, I spoke about it when I was talking about the presentation that we can have AD happening in infants, in children, and in adults. And sometimes adult AD is a persistence of childhood AD that went on, but actually some people can start as adults to experience atopic dermatitis. Fewer than most, but they do occur. So yes, the answer is yes.
I don't know if you addressed it, but someone is asking another important question: if AD is anyway related to asthma.
Okay, it has been spoken about, so maybe the person joined the webinar late. Atopic dermatitis, like asthma, like allergic rhinitis, like food allergy, like allergic conjunctivitis. So AD is one of a tetrad or penta, depending on which side of the divide you stand, is one of the manifestations of atopy, hypersensitivity. So yes, the answer is atopic dermatitis can be and is related to asthma because the triggers of AD can trigger asthma and vice versa. And I had shown that on the slide as well.
There's a question that just came in. Can an AD patient use vitamin C oil? Asking if AD patient can use vitamin C oil. Yes.
Well, I read that, so I'm laughing because I'm not sure why you're using vitamin C oil. So again, one has to be very careful with so one of the things I was trying to not be, I didn't want controversy, is talking about trends on social media, the trending creams and trending skincare practices and trending, and again, so-called natural stuff. Again, we like good stuff. We like good products. We like good skincare. We prefer homegrown things because they will be cheaper. But we are wary and we worry about just anybody becoming a compounder. So, for instance, now I don't know why we would ordinarily just think of vitamin C oil and if what it's supposed to be doing with atopic dermatitis. So I can't answer that question as a yes or no because I don't know why you're using vitamin C oil for an AD patient. So that's the point. There must be more to it. Are there tests to guide on what one is dealing with? A very good question, I think, by Olayinka. So again, in the presentation, I mentioned that atopic dermatitis is a clinical diagnosis, especially in the experts. However, because we have atopic dermatitis mimics and we have um, uh, associated issues with AD, you may need to do certain tests, not to make a diagnosis of atopic dermatitis, but to rule out a few other things and to corroborate your stories. For instance, in complications of AD or in certain areas in flares, if you think that this patient particularly has food allergy or a contact dermatitis, yes, there are tests that we should do, that we can do and we do when necessary for them. But tests to make a diagnosis of atopic dermatitis ordinarily will be a no. However, we can take some skin biopsies sometimes to in certain confusing cases where yes, in certain confusing cases, we can do some biopsies and we know what we expect in atopic patients, especially depending on what severity states they are in. Oh my goodness.
We apologize,
Dr.
Dr.
Hawa,
I'm calling
your mic is on, Dr.
Hawa.
Hawa.
Well, sorry, I'm calling her.
Okay. Dr. Tanya, I don't know if you have any more to say. We should be rounding up.
Yes, I don't know. I can't see any questions except from the live stream, but I don't know if there's any questions there that need to be addressed.
Okay. And from our YouTube audience, Dr. Hawa, any more important questions you'd like to highlight?
Well, I only saw one question that has already been addressed.
Okay.
There's
So,
a
all right. Dr. Mary, were you saying something? Okay.
there
All
is a
right.
I said somebody just posted something, and but I'm not too. I think it sounds like a. Can you see that? I think it's from a doctor. I think.
My son has AD. Is it this one? Is
Yes,
it?
I think I just saw it.
My son has AD that is worse during hot seasons and make him sweat, especially in the flexures. Currently in the UK, and it seems to be presenting differently with worse flares than before. I suspected it may be mold. Will corticosteroid worsen flare from suspected mold, and is bleach bath recommended for this?
So, Dr. Tana, I think you can answer that question. That it's a consultant will probably need to be taken on a one-on-one basis because there'll be
That
more
is,
questions to be asked than just to say yay or nay.
yeah. Said she's asking if it's worse during the, sorry, that is worse during the hot seasons and makes him sweat, especially in the flexures. And she thinks it's mold.
Yes,
Okay.
I heard.
Uh,
I heard. I'm saying
yeah.
that I'm saying
Now,
to give a simple recommendation may not be right at this present moment because there'll be probably more questions. We will need to ask a few more questions than to just go and take just say do this or don't do that. Do you understand
okay.
what I mean? Yeah.
Yes. Okay.
All right. So thank you very much. Um, very much, Dr. Herrera. You always answer when we call. Thank you so much. It was a very, very elucidative lecture. You took it from the very beginning to the end. And I'm sure there are many more questions on people's minds. And Dr. Herrera also shared some links, useful links for AD, including support groups. I would really encourage everybody here, especially patients and caregivers, to join. And the conversation continues. Like AD cannot be finished in a day, cannot be finished in a month. It's a continuous thing. For those of us who um, cater to patients with AD, I know that you've had one or two patients that were quite frustrating. And I'm just wondering, a question from me, have you, from your personal experience, have you had to involve a psychologist at some point for some of your patients? Because sometimes it really gets to that. Okay, sometimes it really gets to that. You find out that the psychological aspect even becomes more important than what's
Yeah.
happening on the skin. Yeah.
Yeah. Yeah, that is
So,
very correct, which is what I was talking about in terms of the mental health support. So just like we said, and you are reiterating, it's not something we can do in 1 hour. But it was important for people to just, just kind of put it in their heads that, look, this is not just a skin disease. It's not just some dry skin. There is more to it. People lose relationships. People stop going to school. People can't afford care. It can be quite bad. And I think if we realize it and we take cognizance of the fact that don't belittle it, even on our part, when I say ours, caregivers, it's not AD. Just moisturize. That just moisturizing is not just because you don't really know what they're going on. So I'm sorry for taking you back, Dr. Onodugo. Just please go on. Sorry.
much. We spent about 1.5 hours, and it was well worth it. I would say it was well worth it. In fact, we should spend more than 1.5 hours on this topic, but we'll have to stop. And we want to say thank you to everybody who joined in this conversation, especially patients, patient groups, healthcare workers from diverse backgrounds, pharmacists, nurses, pediatricians, and every other person who joined this conversation, and of course, all the esteemed members of the Nigerian Association of Dermatologists. We're very happy that you joined this conversation, and we want to say thank you once again to Dr. Herrera for giving this very beautiful lecture. Thank you very much. We will have to wrap it up now, and As the announcement has been made, we'll have a Nigerian Association of Dermatology meeting next month. So there'll be no webinar next month, but the webinars continue in July. Thank you all very much and have a good evening.
Thank
Thank you.
you.
Thank you.
Thank you.
Thank you so much.